Hello, my name is Dr. Abi Lol-Seged. I'm a consultant physician with an interest in endocrinology and diabetes, as well as functional medicine. I've been asked to give you a presentation on adrenal dysfunction and the various ways in which it can present. As with a lot of endocrinology, our journey starts with the hypothalamic pituitary adrenal axis. In the hypothalamus, secretion of corticotroph releasing hormone stimulates release of ACTH from the anterior pituitary, and ACTH in turn stimulates production of cortisol from the adrenal glands. And in a typical adult, over a typical 24-hour period, the body, via the adrenal glands, makes roughly the equivalent of 10 milligrams of cortisol. Now, the cortisol feeds back to the control center in the brain, notably the pituitary and the hypothalamus, to prevent oversecretion, and this helps to maintain homeostasis. I just want to focus a little bit on the hypothalamus. The hypothalamus is responsible for controlling the autonomic nervous system, the endocrine system, as well as the limbic system. The limbic system is responsible for emotions, what some may describe as visceral responses that you might get with fear, with aggression, with anger. It's also involved in feeding and sexual behavior. And for the purposes of this talk, the relevant nucleus in the hypothalamus is the paraventricular nucleus. And it's really interesting because the whole system is integrated with stress responses coming in to stimulate that particular nucleus, but also the sympathetic nervous system. So a variety of stresses can activate the neurons in the hypothalamus, including cytokines, hemorrhage, hypoglycemia. It's not just stresses per se. So if we consider the whole system, it's important to appreciate that although we treat people who have disorders of this system, that the stress response is actually life-saving. It's a very important part of the human body. It helps to prepare us for stressful situations by providing us with adequate blood pressure, adequate cardiac output. There's more blood going to the muscles, more nutrients, there's improved short-term memory and more focus. There's a very interesting study here where model mice were exposed to a shadow. I'll just show you in a moment.
This model is a simple approach in which mice are exposed to an expanding shadow above them to mimic a predator approaching from the sky. We monitor the behavior and record the activity of the CRH neurons and discovered that on the behavioral level, animals either escape to a shelter or froze in place when exposed to this looming shadow. When we look at the CRH activity, we observe that the escape response, but not the freezing response, was always preceded by an increase in the activity of the CRH cells, and also we were able to manipulate that behavior using optogenetics. Next, we asked whether prior stressful experience with different levels of outcome control could alter CRH neurons activity. This model is a simple
if we look at cortisol secretion in a bit more detail, the cortisol secretion starts to rise around 2 o'clock in the morning, and it reaches its peak on waking, and then there's this gradual decline during the day. There are, of course, some excursions during the day, for instance, after meals, as we can see here, but generally what we tend to observe is the lowest concentrations around midnight and the highest on waking. And this would be true for people that have normal day and night patterns. So how do we measure cortisol? Well, there are studies showing that whether it's, excuse me, with serum levels or saliva or with urine levels, there is a good correlation with the measurements of cortisol. You can also use serum and saliva to measure DHEA. Serum is a good modality for measuring pregnenolone levels. And interestingly, it's not just the saliva and the serum cortisol levels that correlate nicely, but salivary cortisone, which we'll discuss very soon, correlates quite nicely with salivary cortisol. So we generally have a number of different ways for analyzing cortisol levels. So if you have an individual who you want to assess their adrenal axis, one good place to start would be the pre-9 a.m. fasting serum cortisol. If the cortisol level taken before 9 o'clock in the morning after an overnight fast is above 350 nanomole per liter, then it's very unlikely that they have adrenal deficiency. If it's below 80 nanomole per liter, then it's very highly predictive of adrenal deficiency requiring urgent treatment. And then you have this gray area between 100 and 350 nanomole per liter. Now, my personal experience is that if the cortisol level is between 250 and 300, it's very unlikely that they have significant deficiency. And the evidence for this comes from personal experience of arranging short synapthin tests, which is the gold standard for ruling out adrenal deficiency in these patients. And with the short synapthin test, what you do is measure before you inject the patient a baseline pre-9 a.m. serum cortisol as well as ACTH, and then you inject ACTH at a dose of 250 microgram, which is supraphysiological. You're effectively mimicking a significant acute stress, and you then measure the adrenal gland response to the injection at 30 and 60 minutes. And you're looking for a 30-minute level above 415 nanomole per liter. It's important to be careful of shift workers that may have abnormal pre-9 a.m. cortisol, but that may be normal for them because they work shifts and sleep during the day, or it may at worst be difficult to interpret just a baseline cortisol reading. If you have an abnormal short synapthin test result, what you want to do is effectively ask the question, where is the adrenal deficiency coming from? So remember, the short synapthin test is helping us to exclude the worst form of adrenal deficiency, Addison's disease or adrenal deficiency from secondary and tertiary causes. And to help us determine where it's coming from, in other words, is it because of disease in the adrenal glands or in the pituitary or hypothalamus, we look at the baseline serum ACTH level. And if the ACTH is low, then this would suggest secondary adrenal deficiency. And the most likely cause for secondary adrenal deficiency is exogenous steroids, which I'll touch upon in a moment. But if the ACTH is high and they've failed the short synapthin test, then you're really looking at primary adrenal deficiency here. And the most common cause in the Western world is autoimmune, whereas worldwide it's infectious causes, particularly TB. Interestingly, and more contemporary, is COVID adrenalitis. So there have been quite a few cases of COVID causing adrenal insufficiency. And the various mechanisms by which this is thought to have happened include parts of the virus, the SARS virus, producing certain amino acid sequences that mimic host ACTH. And this leads to the production of antibodies and the development of central adrenal insufficiency. Additionally, the pituitary and hypothalamus, as well as adrenal glands, express ACE2 receptors, and SARS RNA has been identified in the hypothalamus of patients who've undergone autopsy after death. Thus, the SARS-CoV-2 virus can cause hypophysitis, inflammation in the pituitary gland, as well as adrenalitis, which in turn can lead to secondary or primary adrenal insufficiency, respectively. There are other causes of adrenal disease and Addison's disease in particular from primary insufficiency. So surgical removal of the adrenal glands, metastatic deposits, both adrenals are typically involved in that process. Amyloidosis, sarcoidosis, bilateral adrenal hemorrhage. This might occur in the context of meningococcal septicemia, but even iatrogenically from individuals who are given antiplatelet treatment, for example, after an acute myocardial infarction, where they're given low molecular weight heparin, clopidogrel, aspirin, and so on. Exogenous steroids are very much underreported, if not undervalued, cause of secondary adrenal insufficiency. Adrenal suppression has been shown to occur with tablets, with steroid creams, even with steroid inhalers. Some of them are quite potent, and with steroid drops, as well as intra-articular injections. And generally, with exogenous steroids, particularly if the dose is sufficient and taken for 3 or more weeks, can result in adrenal insufficiency developing. And these are some of the doses of some commonly used steroid preparations. Doses higher than this can well promote adrenal insufficiency if given for 3 or more weeks. So prednisolone at doses 7.5 milligrams once daily or higher for 3 or more weeks, as an example. It's useful to be aware that the effects of exogenous steroids, the serum cortisol reading, can be affected by oral estrogen. So oral estrogen, for instance, in the combined oral contraceptive pill, increases levels of cortisol binding globulin, and so you have more binding of free cortisol, and as a compensatory mechanism the body makes more cortisol, and you get a net increase in total cortisol levels. This doesn't mean the individual has excessive levels of free cortisol, but it's simply an effect of oral estrogen on production of cortisol binding globulin. And if you wish to explore this further, and if it's reasonable to stop the preparation, you can ask the individual to stop the combined oral contraceptive pill, usually for a period of 6 weeks before you re-measure cortisol. So this study showed a number of useful things. Firstly, the effects of inhaled corticosteroids. If you remember, I said to you that some of them are quite potent and have the ability to suppress the adrenal glands. And indeed, in this case, what they did was looked at over 3,500 patients taking inhaled steroids, and a significant number of them failed short synapthin test. And this was more likely to happen if the dose of the inhaled steroid was greater than 400 micrograms. It also showed that we can use random cortisol to predict adrenal deficiency in these individuals. It's noteworthy that quite a few of them are unable to stop the medication for us to be able to test the adrenal axis due to the underlying respiratory condition. And so this study was helpful in defining certain cutoffs. Those individuals that had a random cortisol greater than 359 were very unlikely to have adrenal insufficiency, and those below 35 were very likely to have adrenal insufficiency. And then you have obviously this middle group that constitute a grey area, and those individuals may require referral to an endocrinologist for further characterization, as well as liaising with respiratory physicians to see if it's possible to safely stop the inhalers. Now, this is an extremely important point. If you suspect someone has acute adrenal insufficiency, it is extremely important to arrange prompt investigations, because these individuals are very much at risk of having catastrophic adrenal failure, which can lead even to death. So delaying investigations is very, very much a bad thing. So if we look at adrenal insufficiency, in this case Addison's disease caused by failure of the adrenal glands, the symptoms are very non-specific, meaning that lots of different things can present in a similar way. But if we look at the prevalence of some of these signs and symptoms, fatigue and weight loss was present in all patients, and GI symptoms in the majority of patients as well. In fact, it's not uncommon for these patients to have seen many different specialists, including gastroenterologists, and have undergone endoscopies before the diagnosis of Addison's disease is made. Hyperpigmentation is present also in virtually the majority of patients, and this is due to compensatory release of ACTH, with which melanocyte stimulating hormone is co-secreted. Salt cravings are present in less than 25% of cases, but hyperkalemia is present in 65% of cases. Low sodium and high potassium can be a late sign, so the absence of these classical electrolyte deficiencies should not lead you to think that the person is unlikely to have Addison's disease. So, as I alluded to, the delay in diagnosis of Addison's disease is both unfortunate because this is potentially a dangerous condition, but it's not surprising when you consider the symptoms are non-specific and more discriminating features such as hyperpigmentation is not present in the majority of patients. Also, a lot of the symptoms can develop slowly, and it's not uncommon for individuals to feel reasonably well between attacks. And therefore, about half the cases are actually picked up only in the setting of an acute crisis. Again, for all these reasons, it is possible for the delay in diagnosis to extend to even 6 to 12 months. In one survey, 60% had seen 2 or more doctors before the correct diagnosis was made. So if we have made the diagnosis of Addison's disease, one of the things we want to do is prevent a crisis in which there is insufficient cortisol to address stresses that they may be experiencing at that time. And so the education of these patients is paramount. And I would add to it that also of their relatives and their partners who might be able to help them in an acute setting. So one of the things we evaluate at regular intervals is checking that they're aware of what to do if they're unwell, for instance, if they have an infection, if they've got a significant stressful event such as a driving test or an exam. We discuss the rationale for adjusting the dose during times of stress by increasing it, and also other factors such as nausea, vomiting and diarrhea, which means that they're unable to absorb the hydrocortisone tablets and therefore the need to inject themselves and go to hospital to receive parenteral hydrocortisone. In fact, it's mandatory to make sure that the individual knows how to inject themselves and has the equipment at home to be able to inject themselves as a bridge to going to hospital during times when they are very unwell. there are very good resources online for helping people to familiarize themselves on what to do during a crisis, what constitutes a crisis. So you could see here, it gives them guidance on cutoffs for things that may constitute a significant stress response requiring an increase in the dose of hydrocortisone, in this case, in the context of an infection, as well as if they've got nausea and vomiting. So one way to look at this issue of adrenal dysfunction is to consider that at one end we have Addison's disease, which I have just presented on, and this is the worst form of adrenal insufficiency or adrenal deficiency. And in Addison's disease, you have destruction of the part of the adrenal gland responsible for making and releasing cortisol. And then you have at the other end normal adrenal function, but then there's this middle section called maladaptive stress response or increased allostatic load, leading to dysfunction of the hypothalamic pituitary adrenal axis. And this leads nicely to cortisol and the stress response. And what I'd like to do firstly is to define allostasis. Allostasis is essentially the body's ability physiologically to help the person cope with changes to the environment. If you like, it's the combination of the body's responses to stress that help the brain and body to return to optimal functioning, homeostasis. And allostatic load is the wear and tear on the body which accumulates as an individual is exposed to repeated or chronic stress. So effectively, if you have an appropriate stress response, in response to a trigger, the stress response goes up, but then it's returned back to baseline. But with repeated exposure to stresses in a chronic maladaptive way, there is a new set point and a failure to return back to baseline, resulting in maladaptive stress response. This is effectively the price the body is paying for that stress response that's just not switching off. And chronic stress is not healthy because if you have continuous or frequent release of cortisol, there's activation of the HPA axis. And the immune cells, as in part a protective mechanism, downregulate cortisol receptors. They produce inflammatory cytokines, and the repeated stress can cause damage to the hippocampus. And cortisol is then no longer able to regulate the inflammatory and the immune cells, leading to a state of cortisol resistance. That cortisol resistance in turn leads to a compensatory increase in even more cortisol production, and eventually there is an inability to produce enough. Chronic stress has been shown in many studies looking at a variety of different situations to be pro-inflammatory. This is one of the ways in which it becomes maladaptive or unhelpful. So with vigorous exercise, levels of interleukin-6, this pro-inflammatory cytokine, goes up, and it's lower with moderate or low-level exercise. It's interesting that interleukin-6, amongst other things, promotes insulin resistance and visceral adiposity. And if you look at knockout studies in mice that have IL-6, inability to make IL-6, they have less despair behavior to stress. Conversely, if you look at patients who are depressed, clinically depressed, they have higher levels of interleukin-6. And furthermore, if you infuse IL-6 into volunteers, it induces depression, difficulty concentrating, and fatigue. And if you then add in an IL-6 receptor antagonist blocking the actions of IL-6, that leads to reduced chronic fatigue. But it's not just IL-6 that's elevated. You also see other cytokines, including but not limited to TNF-alpha as well as interleukin-1. So the effects of chronic cortisol production, this increased allostatic load, is really unhelpful. So instead of the initial stress response being a helpful thing to the body, what you find is with chronic stress, there's increased visceral adiposity that leads to metabolic syndrome. Metabolic syndrome predicts cardiovascular disease and type 2 diabetes. You also find dysregulation of blood glucose. There is cognitive decline because the hippocampus gets damaged and atrophies. And this leads to combination of issues. It also affects sleep. There is reduced serotonin response and melatonin, from which one makes serotonin. There's also dysregulation of the immune system. One can see reduced bone mineral density and IGF-1. And because the gut and the brain are hardwired, it's not uncommon for stress to cause problems with increased intestinal permeability, as well as small intestinal bacterial overgrowth. Women who are stressed can upregulate production of aromatase, and this in turn leads to increased production of estradiol, leading to imbalances in estrogen and progesterone. And the net effects of that can present in a variety of ways. It can present with significant PMS symptoms or PMDD, with heavy or painful periods. It can also cause anovulatory cycles. And stress also can drive problems with reduced libido. It's generally a very insidiously harmful thing. So if we focus on stress, serotonin and melatonin, what we see is that increased cortisol as a reduction, as a consequence of stress, with or without inflammation, can in genetically susceptible individuals lead to a stealing away of tryptophan to make this acid, chyronic acid. This can, amongst other things, cause muscle pains, but because there's this tryptophan steal, what you find is there is less material to make serotonin. And these individuals can present with a variety of symptoms and problems. So they may want to pick at food in the evening. They may struggle to get off to sleep, or when asleep, they wake up and their mind is active. They can't switch it off. They crave carbs more than they would otherwise. And it can also lead to chronic pain, as well as OCD type behavior. And because serotonin is necessary for the production of melatonin, their sleep, as I just mentioned, is affected. One of the other things that chronic stress can do is drive mast cell activation. So there's this new concept, this new condition that's been identified in the last decade called mast cell activation syndrome. Although it's a new disorder, there is thinking that it might actually have existed for a very long time, and may have been not necessarily given a label until recently. But essentially in this condition, what happens is the mast cells are more likely to degranulate and release their contents in response to a variety of triggers, leading to a variety of symptoms dependent on where the mast cells are that are releasing their contents. But one thing that's evident is that stress is a key trigger and releaser of the mediators. So what you see in this cartoon is a mast cell degranulating and releasing its contents, which in turn causes a variety of different symptoms. The gut mast cells can be activated by CRH, and it's precisely because these mast cells have receptors for corticotroph releasing hormone that stress is implicated as a key driver of the condition. So in terms of biomarkers and what we measure if we're trying to determine the effects of maladaptive stress response. It's not too difficult. Cortisol is the most important biomarker for stress, and it therefore constitutes an important measurement for the detection of chronic stress. So thankfully, as I showed you in the earlier slide, saliva levels of free cortisol correlate very nicely with serum, and therefore constitutes a non-invasive way of measuring levels. DHEA is also, certainly this has been borne out by studies, shown to be a biomarker of acute stress in as much as the levels can rise both in the saliva or blood with acute stress, and with prolonged stress, especially maladaptive stress, DHEA levels can fall. DHEA is made both by the gonads, so ovaries in women, testicles in men, and adrenal glands. But it gets converted in the adrenal glands to DHEA sulfate, DHEAS, and DHEAS is made solely by the adrenal glands, and therefore may be a more stable marker of DHEA levels. It's interesting that there are some studies that allude to the fact that one can have normal DHEA levels in someone who is unwell when the DHEAS level is low. So just a quick word on the metabolism of cortisol. Cortisol is converted to cortisone via 11-beta hydroxysteroid dehydrogenase type 2 to cortisone. And although cortisone is inactive, it can get converted back to cortisol, which is active, via the sister enzyme 11-beta hydroxysteroid dehydrogenase type 1. So there's this bidirectional relationship. Cortisol is further metabolized to inactive metabolites, tetrahydrocortisol and allotetrahydrocortisol, and cortisone to tetrahydrocortisone. Now, there are some providers that will give you levels of both cortisol and cortisone, as well as the ratios. And this can be very helpful as there are certain conditions. For instance, if you have high cortisol and low metabolized cortisone, that may indicate conditions such as hypothyroidism. And if you have high cortisol and high metabolized cortisone, it can be associated with obesity. In acute stress, one sees a rise both in cortisol and the cortisol metabolite, tetrahydrocortisol. And with chronic stress, you tend to see less cortisone metabolites. But it's also interesting, we mentioned inflammation and inflammatory cytokines, but chronic inflammation is a potent inducer of 11-beta hydroxysteroid dehydrogenase type 1 enzyme, leading to the production of even more cortisol, which makes things more maladaptive. And other causes of increased type 1 activity include overactive thyroid, insulin resistance, nocturnal pathologies such as obstructive sleep apnea. And in these situations, the free cortisol can be high, normal, or low, but cortisone is elevated. Licorice inhibits type 2 enzyme, helping to keep up levels of active cortisol. We sometimes find that licorice can be a useful addition for individuals that have low normal levels of salivary cortisol in the decompensated phases. So if we look at the maladaptive stress response, some individuals have characterized 3 phases to try and describe what can happen at various times. So stage 1 would be a normal adaptation to stress with increasing stressful stimuli. You get early decompensation and then late decompensation. So if we try and go through some of these stages, in stage 1, the adaptation phase, this is sometimes described as the alarm stage. There is acute stress, and the hypothalamic pituitary adrenal axis responds to this by producing more cortisol via increased levels of ACTH, which also drives the production of DHEA in the adrenal glands. But it is possible also to see normal DHEA levels. They don't necessarily have to be increased, but the cortisol levels are elevated, and they can be elevated at different time points, not necessarily throughout the day. The other observation here is that you see that although it's elevated, it is dropping as the day wears on. Here we see an example of a normal morning cortisol, but elevations late morning and mid-afternoon. In my experience, the two most common causes for this are external stressors. This might be the meeting in the office, or secondly, fluctuations in blood glucose. Anxiety can also drive this, but one tends to see this in circumstantial conditions. Here we find elevated morning cortisol. This can be seen in individuals that have nocturnal pathology. They may wake early. This might be associated with poor sleep, exercise, pain, or even hypoglycemia. Elevations in cortisol, salivary cortisol levels late morning and at bedtime are particularly important because studies have shown that they're associated with neurocognitive deficits as well as increased cardiovascular mortality. They can also be associated with poor sleep quality. And so this is something that would and should make us look at cardiovascular risk factors such as visceral adiposity and metabolic syndrome, as well as addressing, amongst other things, their sleep quality. Now, we talked about adrenal deficiency, the worst form of adrenal related issues from a underproduction perspective. But if we look at the opposite problem, excessive production of cortisol, in this case Cushing's syndrome, this is an incredibly rare condition, and the salivary cortisol profile for someone with Cushing's would be very high levels that do not really settle as the day wears on. It's like a sawtooth appearance, but almost flat and very high. And the clinically discriminating features of Cushing's are very wide purple stretch marks and thin skin which bruises easily, as well as proximal myopathy. So you could ask them to fold their arms and stand from a seated position, or indeed test for muscle weakness in the thighs and the shoulders. But otherwise, more common causes of persistently high cortisol include chronic stress, chronic insomnia, psychiatric conditions such as bipolar disorder and generalized anxiety disorder, and bowel conditions like SIBO and irritable bowel syndrome, although those issues are also linked with anxiety. So another measurement we look at is the cortisol awakening response. And this is a very interesting and helpful measurement. It looks at the ability of the individual to meet anticipated challenges. So it's looking at the rise in cortisol in the first 30 minutes of waking. So if you remember, we talked about how the Short-Synapthen test is the gold standard test for ruling out adrenal deficiency or Addison's disease. Well, the cortisol awakening response is like a mini stress test for the hypothalamic pituitary axis. And typically, what you're doing is looking at the rise in cortisol in the first 30 minutes. And you want this to be a figure between 50 to 150%. Now, if it's below 50%, causes for this include PTSD, chronic fatigue, depression, bereavement, loss of memory, and sleep disorders such as obstructive sleep apnea. And if it's elevated, then you may see this in individuals who are anticipating a very stressful day. They're effectively, the body's gearing up to meet the challenges of the day. So the second stage is early decompensation. And what you effectively see, and the best way to describe this, is a roller coaster profile. And the profile also happens to mimic their symptoms. So they're on an emotional roller coaster. They're very tired in the morning, then they get a second wind in the evening when they feel more energized, and this unfortunately leads to poor sleep, driving the issues. They're tired in between and at other times. And typical findings can include reduced DHEA, but cortisol has this elevated, but also, as I mentioned, roller coaster profile. And then the final stage is essentially associated with chronic fatigue, sleep issues, and it's a relatively flat salivary cortisol profile. And the DHEA levels are typically low in this condition. And patients may present with significant fatigue, not just in the morning, but throughout the day. But particularly in the morning, they are very groggy, takes them a while to get going. They may have orthostatic symptoms such as dizziness and lightheadedness due to low blood pressure, and they may crave salt as well. Another measurement of chronic stress is the heart rate variability. So we know that there is significant variability between one beat to the next, and that the heart rate variability looks at the time interval between successive heart rates. So it turns out that it's not constant from one beat to the next. And this rate is governed by the balance between the parasympathetic nervous system and the sympathetic nervous system. So higher values can suggest more cardiovascular fitness and more stress resilience, but it can also indicate pathology, so it may have to be interpreted in the clinical context. There are quite a few devices that can now measure this for the individual. They don't have to be done in a clinic setting and provide real-time feedback. So if we move on to treatments, so reducing stress is extremely important. Although there's quite a lot we can do for our patients, the one thing that I tell my patients that I can't do for them is what they do at home, at work, wherever the problem is. So identifying the stress and having sometimes the courage, having the insight, the help to remove oneself from the significant stresses is very important. Of course, there are some situations in which it's not easy for the person to just leave. For instance, if they are in a toxic workplace environment but need the finances. But there are others that may be more simple, such as toxic friendships and toxic people, as well as toxic demands that sometimes the individual places even on themselves. It's not necessarily coming from others. And so stress reduction strategies are crucial. And it's useful to advise our patients that it is possible to try and achieve excellency or aim for excellency, but not necessarily at the cost of driving oneself to the ground. And there's some additional treatments that we mustn't ignore, not least because they're effective and complementary. So a lot of these will activate the calming or parasympathetic nervous system, is how I explain it to my patients. And they're backed up by studies. So in one study, there was a 67% reduction in salivary cortisol levels just by laughter. What they did in this particular study, looking at individuals with end-stage renal failure having dialysis, was essentially to ring them up and just get them to laugh out loud at the end of a phone line. And that showed reductions in salivary cortisol. Deep breathing, so there are a variety of ways to do this, but one is where you take a deep breath in over 2 seconds, hold for 2 seconds, breathe out over 2 seconds and hold for 2, and the cycle can be repeated. Cold showers can be very effective as well. Anywhere I've heard from some people advocate you just need a minimum of 10 seconds, others 2 minutes can be useful. I would advise individuals who have epilepsy to be very cautious of this though. Classical music can be good. Certain frequencies in music can positively influence the brain, and I would also add other frequencies can be harmful. Short naps, very often 10 minutes if not longer during the day, where if you can get away, switch off the phone, just close your eyes even if you don't sleep. This can be very useful. And trying to develop social and community connections with non-toxic relationships can be immensely helpful. So another treatment that we often overlook or can be overlooked is reactive hypoglycemia. This is an extremely common problem, very common particularly in individuals with chronic symptoms such as fatigue and maladaptive stress response. Because for a number of reasons, including ones we discussed earlier, chronic stress is associated with serotonin demand, and that in turn can lead to increased carb cravings. You can get pro-inflammatory cytokines that promote visceral adiposity. And so all of these factors can lead to fluctuations in blood glucose. Typically what happens here is if the individual consumes carbs, this can be both good and bad carbs, such as bread, rice, pasta, potato, fruit juice, cereal, porridge, cake, sweets, chocolates. Blood sugars go up and then they plummet. And when they plummet, so this is data from an actual patient showing a nadir, blood glucose just above 2.5 in response to glucose. When it drops to a low level, then this is associated with release of cortisol and counter-regulatory hormones such as catecholamines and growth hormone and glucagon to mobilize glucose stores. And the repeated events can lead to excessive cortisol production. There are a number of conditions that can be linked with reactive hypoglycemia. It's not necessarily just present in overweight individuals. It can happen after significant weight loss. So if someone is dieting and has managed to lose weight and then starts to add carbs back in, they may be particularly sensitive. We've discussed that it's particularly an issue with carbohydrates, but also micronutrient deficiency such as vitamin D can drive unhealthy insulin dynamics. Alcohol can do this. Infection with Helicobacter pylori is also connected with reactive hypoglycemia. Studies show that within 1 month of eradication therapy for Helicobacter pylori, there were significant improvements in mixed meal glucose readings and significant reduction in attacks. Artificial sweetness can, within a very short time, disrupt secretion of insulin. So in patients that we see with maladaptive stress response and increased allostatic load, it's really important to look at the diet, particularly with a view to reducing, where relevant, the carbohydrate intake and having proportionately more healthy fats, and to a less degree, moderate intake of protein. So the other area that we want to concentrate on if we're going to improve stress resilience is sleep. Sleep is absolutely crucial, good sleep quality for maintaining healthy stress response and countering maladaptive stress response. So if there is mast cell activation syndrome and symptoms of that condition, you may wish to consider a sedating antihistamine at night. Use of melatonin, especially if there is symptoms to suggest maladaptive stress response linked with increased demand for serotonin can be useful, as well as correcting the micronutrient demand. So in the context of poor sleep, this can involve magnesium and vitamin B6. The timing of meals is important. Eating too late in the day and then going off to sleep within an hour and a half can lead to disrupted sleep. It's good to leave at least a 2-hour gap between the last meal and when the individual goes to sleep. And it's noteworthy that if you are able to facilitate deep sleep, you also help the individual to make more growth hormone, which suppresses cortisol. One particular supplement that can be extremely useful with high and maladaptive levels of cortisol is phosphatidylserine. This is a natural phospholipid which is present in high concentrations in the brain. Studies show that it can help to actually reduce cortisol levels and anxiety and improve sleep. It's very important to make sure we don't miss gastrointestinal factors that might be promoting maladaptive stress response. As mentioned earlier, the brain and the gut are very much connected, with problems in one affecting the other and vice versa. Typically, I find that individuals with small intestinal bacterial overgrowth and gut dysbioses are also more likely to have symptoms and features of maladaptive stress response and abnormal salivary cortisol profile readings. It's interesting and noteworthy that the gastrointestinal tract makes more serotonin than the brain does. So in terms of micronutrients, there are ample studies showing that they are hugely implicated. So for instance, the B vitamins are useful in regulation of blood glucose. They're essential for methylation, in particular vitamin B6, B12, folate, and methylation in turn helps in the production and clearance of neurotransmitters, recycling of the energy currency, production and repair of DNA, even clearance of histamine. So they're absolutely crucial, but in this context in particular, the production of serotonin and melatonin. The adrenal glands have a very high concentration of vitamin B5 and vitamin C, and deficiency of vitamin B5 has been associated with reduced cortisol production. Vitamin B5 also stimulates production of corticosterone and progesterone. In one study, when levels of certain interleukins, notably interleukin 10 and cortisol following a marathon race, were measured and found to be the interleukin 6 receptor antagonist and epinephrine levels were lower in the group that had been pre-treated with vitamin C at a dose of 1,500 milligrams daily for 7 days prior to the race. Magnesium deficiency can also exacerbate the stress response. Magnesium is crucial for the activity of over 300 enzymes, but also helps in the methylation pathways and in the production of neurotransmitters, as well as melatonin. Omega-3 fatty acids are also very important in this context. Just a word on adrenal extracts. Because they contain the active ingredient, they can suppress the hypothalamic pituitary axis, and they can also make it difficult to address the underlying causes as well as investigate them. There are studies also showing that in 12 adrenal support supplements or adrenal extracts, all contained bioactive levels of ingredients not declared, including some hormones which in turn may, in high doses, have a negative effect on the axis. As a rule, I prefer to work out the underlying factors that are driving the maladaptive stress response and to address them. And very often this method is sufficient in the majority of cases, such that one doesn't have to resort to adrenal extracts. And the other observation is that, of course, if there is significant deficiency, then we have the ability to use the actual compound itself, or compounds such as hydrocortisone for cortisol and DHEA. We have established that maladaptive stress response is associated with increased production of inflammatory cytokines, and therefore using treatments to reduce these inflammatory cytokines is very useful. One particular product I like is Qaux. This has active ingredients including black tea extract, N-acetylcysteine, curcumin, vitamin E, and resveratrol. And in clinical studies, it's been shown to improve pain and sleep, which are indirect or surrogate markers of the inflammation process. And it's been shown to have reductions in inflammatory mediators. So another treatment modality is this concept of adaptogens. There are a wealth of studies coming out of Russia between 1940 and 1990, when after the 1990s we started to see more Western studies. But essentially the Russians first used it in their military and cosmonaut programs. And the best way to describe what adaptogens do is help the body to produce the right amount of cortisol for a given situation. So not too little when more is needed, and not too much when less is needed. And it's been shown to enhance the body's stability against physical loads without necessarily increasing O2 consumption. So it's a useful treatment for increased allostatic load. There are quite a few studied. I've picked the ones that there's quite a lot of study data for. Rhodelia has its therapeutic effects within 30 minutes, and it persisted for up to 6 hours. And studies have been shown for this particular agent to reduce fatigue. It increases mental performance, concentration. It also decreased the cortisol response to awakening stress, importantly in individuals who were at risk of clinical burnout and chronic fatigue. It's also been shown in animal studies to help with recycling of ATP by the mitochondria. And in students, it was shown to reduce self-reported anxiety, anger, and confusion. Night shift workers who were given Rhodelia saw a 20% improvement in fatigue index, composite of mental performance, short-term memory, calculation skills, and concentration. The other adaptogen that has been well studied is ashwagandha. This has been shown in studies to reduce markers of stress. It reduces serum cortisol, and it may even help to enhance, certainly animal studies bear this out, conversion of T4 to T3. In other studies, although admittedly this was based on questionnaire derived data, it improved body weight and body mass index, as well as food cravings. One particular product, HPA Control, has both ashwagandha and Rhodelia in it. Another product is Siberian ginseng. Ginseng is a very important antioxidant that helps to suppress oxidative stress, and it's neuroprotective. It has been thought to and shown in studies to help with neuroplasticity, particularly in the hippocampus, which may help with memory in the context of chronic stress. And it may be useful in depression as well. Certainly in one study, the efficacy of ginseng was similar to fluoxetine. There are intranasal preparations, so the hippocampus is quite close to the nasal cavity. The nasal cavity at the uppermost connects with the basal center part of the brain. And this particular product, RG3, is a nasal spray that contains Siberian ginseng. So we've touched on licorice, its ability to elevate cortisol levels, but there are over 400 compounds in licorice itself, and in addition to helping to promote elevations in cortisol, so this might be a useful option in individuals that have a flat cortisol response. That's stage 3, the late decompensation phase. But licorice is also thought to have anti-inflammatory, antioxidant, anti-tumor. It's gastroprotective. It has antimicrobial properties as well. And it's thought to not only increase cortisol, but also DHEA levels, and can help with elevating blood pressure through mineralocorticoid activity. Pregnenolone is an adrenal product. It's one of the raw materials that's used to make the other hormones by the adrenal glands, but it's also a neurosteroid which has actions in the brain in helping to improve memory, but also possibly depressive scores. It is possible to measure serum pregnenolone levels, and may be worthwhile considering in some individuals, particularly those with very significant stress response. DHEA is a very interesting hormone. It's actually labeled a sex hormone precursor because of its ability to be converted to estradiol and testosterone. But studies show that it may help to reverse the acute effects of stress. It may help with psychological well-being. It has immunomodulatory properties, so it can actually help to improve the activity and function of natural killer cells. It has anti-inflammatory properties. It increases bone mineral density. It can help improve libido. There is a vaginal preparation of DHEA, and the benefit of that is that it can get converted to testosterone and estrogen, and this may help to promote the health of the vaginal cells, as opposed to just an estrogen-based product, although there are no head-to-head comparison studies that I'm aware of. So the data supports small benefits in quality of life and mood, but not for anxiety or sexual function in women with primary or secondary adrenal insufficiency or anorexia. So the rationale for this statement is because DHEA is made in part by the adrenal glands, and in individuals that have adrenal insufficiency where the adrenal glands are not working either because the adrenals themselves are damaged or the control center is not working well, has led some to speculate if DHEA should be routinely replaced. Their conclusion, therefore, is that there are small benefits, but insufficient to recommend wide-scale prescribing. My experience is that in individuals that have low levels, this can be an immensely helpful addition. And at the very least, it's important that we exclude deficiency so we don't miss those individuals who are likely to benefit from it. Now, the dosing is very important. In the worst case scenario, if you give postmenopausal women too much DHEA, it can get converted to estradiol and promote in susceptible individuals breast cancer. And in the UK at least, DHEA is unlicensed, and so I tend to consent my patients before prescribing this and use doses that are appropriate for men and women, and for women depending on the stage of their life. The dose sometimes needs to be modified, and I monitor DHEAS levels, bearing in mind that DHEA gets converted to DHEAS, and serum levels of DHEAS may provide a more stable marker. So I conclude by highlighting the novel treatments that are around or emerging. So electrotherapies can be very useful for very significant stresses. And we're also seeing a role for peptides, some of which may be useful for stress or the consequences of stress, such as poor memory. So for my last slide, this is really a message to colleagues. What about us? We are in a profession that is demanding, and we strive for excellence, and this may come at a cost of significant stress response. And it is important that we make sure that we manage our stress levels, because to the extent that we can do this, not only does it have a good bearing on our health, both mentally and physically, but from a position of greater resilience, we can offer more to our patients. Doing salivary cortisol profiles on ourselves, identifying stressors, trying to provide a good service whilst making sure it doesn't come at a huge cost to us, and trying to understand, therefore, our service, how we work, working to our strengths, hiring others to help us take some of the pressure off. These are some of the factors that perhaps we need to consider. Thank you.